Hi class, welcome to the unit where we discuss everything to do with the OR. Um, we're going to start off with preoperative nursing, but I do want to just touch base on the 3 stages of the surgical procedure. So we've got the pre-op stage that begins when the decision to schedule a surgery is made, and it ends when the patient is going into the OR. Then there's the intraoperative phase, which is basically the OR bed, and then it ends with admission to the PACU. And then the post-operative phase begins with the PACU and then ends up when they are discharged to home, or it even continues until their first post-op checkup. So those are just some basic definitions. There are different types of surgeries. We can do it, we can schedule a surgery to facilitate finding out a definitive diagnosis. We can do a surgery to cure a problem or repair an issue. There can be reconstructive, cosmetic, or palliative. They can be rehabilitative. There's also degrees of urgency. You can have emergency, urgency, required, elective, optional. An example of an emergent surgical procedure would be to repair a perforated ulcer. An urgent one would be maybe a fracture. Required would be maybe they're going to remove like a slow growing tumor. An elective could be something like a breast augmentation or breast reduction. Sorry about the barking there. I think I have quieted them down. I apologize. So those are just some examples to offer you some insight as to like how quickly do we need to get this taken care of, and gives you some insight into scheduling. So then we get to pre-admission testing. It begins the process of getting them ready for surgery. The big thing with preoperative is we want to identify any potential complications that could influence the process of the surgery or the recovery process. So we're going to get a large amount of admission data, a detailed health history, and anything else that could be pertinent to the type of surgery that's being performed or scheduled. We're going to verify that we have the correct reason for the surgery. And we're actually going to begin the discharge planning, because when we are assessing all the factors that go into the patient's current status, that's when we start identifying outcomes and possible complications that we need to take steps to avoid from occurring in the post-operative phase. It's also when we want to start preparing them for what are they going to experience once the surgery is complete and they are on the path to healing. So an example I can offer you is, what if your patient is diabetic? Well, just knowing that your patient is diabetic, we're going to closely monitor their blood glucose. Pre-op, inter-op, post-operatively. When we're getting them ready to go to the OR suite, if we're going to be hanging any IV fluids, we've got to know what's their blood glucose and what type of fluids have been ordered by the physician, and is it appropriate? If they already run a little bit high, do we want to give them a whole bunch of dextrose? Because that could make them go even higher, increasing the risk of infection, delayed healing. We could push them so high that it'd be dangerous to move forward with the surgery. So these are things that we need to take into consideration, not just the surgery, but what about the person that we are preparing for surgery? Some additional information that we would want to know is how do they manage their blood glucose? Do they take oral meds, IV med, or excuse me, sub-Q meds? When was the last dose? What's their normal dietary habits? Are they on long-acting, short-acting insulin? All those things come into play when we're preparing for surgery and we're taking care of a patient post-surgically. So this is also part of the vital information that has to be passed along through each stage of the surgical process. So let's move forward to the day of OR. So we said pre-op begins when the patient is scheduled for surgery and ends at the time of transfer to the surgical suite or to the operating room. Our role as nurses we're educator, patient advocate, promoter of health, and we're keeping an eye on safety the whole time. So, like I said, we're going to do a health history, a physical exam. We're going to do medication reconciliation. We're going to double and triple check allergies. We're going to assess nutritional fluid status. We're going to take a look at their teeth. Most surgeries require an artificial airway or have the risk of over-sedation. And dentition is a role. Do they have loose teeth that we need to worry about getting knocked out or impeding the airway? Do they have a history of drug or alcohol use? Because that's going to have a factor in how their body processes anesthetics and pain medications. So that would be information to relay to the anesthesiologist. What's their respiratory cardiovascular status? How well do their kidneys and liver function? Do they have any endocrine or immune system issues? Any psychosocial factors like claustrophobia, any spiritual, cultural beliefs. This is also when we start our post-op teaching. So it should start as soon as possible before the surgical procedure. We need to assess, is there any potential need for blood products in this? Is blood loss a risk, a potential complication of the surgery they're going to have? If that is a factor, do we have blood drawn for a type and cross before they go to the OR suite so that we have blood as soon as possible if they need it? If it's a woman of childbearing age, do we have a pregnancy test? Because remember, if we give anesthesia, it will be affecting the fetus as well. So all of these things are specific examples you want to have in your mind when you're thinking about the constellation of things that are going to be affecting the patient intrasurgically and post-surgically. We're going to be talking to them about any types of tubes, drains, or equipment they may have before, during, or after surgery, like maybe an incentive spirometer. Maybe they're going to have a JP drain that they're going to have to take care of. It's good to let them know before that is an issue so that they can wrap their mind around being prepared to take care of that. If you've got a patient that's having an abdominal surgery, you're going to need to, like maybe they're getting a colostomy. Well, they need to know what to expect with that colostomy, how to take care of it. If they're having bowel prep, you've got to make sure if we've given them anything that we don't get them up to the bathroom, that maybe we use a bedpan or they don't get up alone. Minimize safety hazards, side rails up, bed in low position. Older adults can sometimes have confusion as a problem post-surgically, so we need to take steps to mitigate the risk of them having a lot of confusion post-operatively, pre-operatively. So making sure that they have visitors, that we talk to them about coping mechanism, that they're clean and comfortable, that they're getting adequate sleep. So all these things come into play when you're taking care of a patient? Do they have hearing aids? Do they have dentures? Do they have a latex allergy? High priority information to make sure it is relayed. Did they stop eating and drinking the right time to even move forward with the surgery? Do they need education about the type of anesthesia that they're going to receive? Do they need considerations for activity after? So it's very, very comprehensive preparing a patient for the OR. And an ounce of prevention is a pound of prevention of a complication. So we want to have a good plan in place. And this slide just plants some seeds of medications that should trigger us to use our critical thinking if on how that could affect the progress of the surgery and post-operative care. Okay, because hydration status is a very big thing with surgical patients, as is level of consciousness, sedation, blood glucose, how they respond to stress, risk for bleeding. All of these are issues. If they're on, let's say, metformin, does that need to be stopped prior to any type of procedure that's going to use contrast? If they take any herbal remedies that increase the risk of bleeding, maybe that needs to be stopped several days before surgery. If they're on Coumadin, that's got to be stopped several days before surgery, but then they also need to be on a bridge anticoagulant so that they don't develop clots while they're waiting for surgery. There are some specific considerations for older adults. They have decreased organ function as a general rule just because of the aging process. So cardiac reserves are going to be lower. It's going to be harder for them to compensate respiratory wise. They've got decreased subcutaneous fat. So they are more fragile with temperature changes. They may need more time and multiple explanations to understand and retain restrictions. So we may need to reinforce these over and over and over with each communication so that it's clear in the patient's mind. There are also special considerations for certain patient populations. Patients who are obese, a lot of times they are hypoventilators just because the adipose in the abdomen takes up more room and then the lungs are not able to expand as fully. Patients with disabilities, patients that are going to be discharged to home right after the PACU and the step-down recovery. Patients that are going right into emergency surgery. So even if a patient is emergently going to the OR, we still have to do all this assessment, but we just do it much faster. It still has to be done. We want to also assess for the risk of venous thromboembolism, which is sometimes abbreviated VTE. And those patients at high risk for VTE, i.e. blood clots, include the morbidly obese, anyone that's going to undergo a prolonged surgical procedure, anybody who has a risk for decreased venous circulation, and that includes people that have heart failure or who are non-ambulatory. Okay, so then another important concept is informed consent. It needs to be done before surgery. It is your job as the nurse to make sure there is a signed consent. If there is not, you need to call the surgeon and make sure that they sign it and talk with the patient. As a nurse, we cannot sign informed consent forms because we are not the ones that are going to be doing the procedure. You can give the patient information to educate them, but the doc has to be the one to sign it. Another important consideration is the surgical site must be marked by the surgeon prior to the surgery. If this hasn't been done, you again have to call the surgeon and have them come and do it. And this needs to happen before your patients have received any psychoactive pre-medications. And if we're assessing if informed consent has been obtained, the patient should be able to explain the procedure and the most common risks using lay terms. If a patient says that they aren't sure or don't really understand, that means informed consent has not been fully done. And we need to call the surgeon and have them come and talk to the patient. So we can clarify, confirm, and witness, and then we have to make sure that consent goes with the patient to the OR. That is very, very high priority duties that we are responsible for facilitating and ensuring is completed. So then we've got some kind of things that we just have to do, tasks to do. We've got to get them in a gown, take a look in their mouth, get jewelry off, store their valuables securely, give them any pre-anesthesia med, like for example, maybe they're going to get a benzodiazepine to help manage preoperative anxiety. We're going to start that preoperative record and document everything. Remember, if you don't document it, it hasn't been done. We're going to talk with them about deep breathing, coughing, incentive spirometry. We're going to talk about mobility, active body movement to help prevent venous thrombosis, pain management, cognitive coping strategies, any instructions that are specific for a patient that's undergoing ambulatory surgery. So a lot of education and collaboration with the patient in that preoperative stage. So our general interventions are providing psychosocial interventions to reduce anxiety, keeping the patient safe, managing nutrition and fluid, preparing bowels, preparing skin. Some other considerations is like if your patient has a chronic lung disease, they may need a nebulizer prior to surgery. Maybe they haven't been diagnosed with a chronic lung condition, but they tell you that they smoke daily, especially several packs. We may want to be proactive and make sure we get a nebulizer order and treatment done prior to being intubated. We're going to monitor their oxygen levels. We're going to closely monitor their respiratory rate and quality of respirations. Know that it's common to help to give a pre-op med to help calm the nerves. If that happens, our interventions include monitoring respirations and blood pressure. We need to be reassuring of the patient and keep them safe. Don't let them up to the bathroom if we have given them anything like that. And then, of course, if your patient has an advance directive or living will, we must make sure the OR team knows about it and there is a copy of it. This assigns who is going to make the patient's healthcare decisions in the event that they are unable to speak for themselves. And anytime someone is getting sedation, we need to have a backup person and know the plan of care. So I would stress to you that doing a holistic assessment and then communicating and documenting is a critical role that the nurse plays in preoperative care. And that leads us to the actual operation. So there's members of the surgical team. Of course, the patient is our priority. There's an anesthesiologist who is a physician or a certified registered nurse anesthetist. There is the surgeon, there are nurses, there are surg techs, there are surgical technologists or registered nurse first assistants. The priority, as soon as you step into that OR surgical environment, there's different zones that you need to be cognizant of. There's the unrestricted zone where you can wear straight clothes, the semi-restricted where scrub clothes and caps, and then the restricted. You've got to have your shoe covers, your caps, your masks. We are going to maintain surgical asepsis in those zones. So anything and everything that we can do to minimize the presence of microbials in a surgical environment is critically important, and you must adhere to those restrictions. These are the basic guidelines for surgical asepsis. Because the surgical site is a sterile environment. One thing that I want you to know is that you have to have a mask on first. If you breathe on anything, it is immediately contaminated. The other thing is do not be afraid to call out someone for breaking sterile field, because it is for our patient's safety, not convenience. So all of these rules must be adhered to 100% of the time. And I'm not going to read you what's on the slide because you guys can read, and it's continued on the next slide. But you do need to notice and be aware and maintain each of these guidelines. So then there's team roles within the surgical team. The circulating nurse, scrub nurse, registered nurse first assistant, all of these require advanced or further training after you graduate from school. So we're just going to touch on the main roles here. For example, it's the responsibility of the scrub nurse to make sure that everything is accounted for, and that includes every single surgical instrument and every single gauze. So we have to keep count what goes in, what must come out. And the surgeon cannot close the patient up unless everything is accounted for. Because if we leave something in the patient, we are guaranteeing a complication, infection, possibility of sepsis and death. The patient's life is literally on the line. Then there's the circulating nurse. The circulating nurse's role is to ensure that the patient's safety is first and foremost. She or he monitors everybody who leaves and enters the room, as well as all activity within the room. They also participate in the handoff communication as the patient moves to the PACU. We are our patients' advocates. That is our role. So then we've got this intraoperative, kind of how everything kind of meets together. So I really like this slide. Take a minute and just look at all the things that come into play. And it's just really kind of a cute and concise summary. So one thing that's important to know is what type of anesthetic is used in a surgical procedure. For example, if a patient is getting spinal anesthetic, that carries the risk post-operatively of a spinal headache. And we know we need to keep the patient supine while they recover to prevent a spinal headache from forming. This is also when, remember, we need to take into consideration, do we need some blood on hand? A type and cross mat needs to be drawn. This is when we need to start thinking about intraoperative complications. What could go wrong? Well, they could have anesthesia awareness, so they aren't fully under. So we're watching those vital signs super closely for subtle changes. Because usually they're going to be immobilized, so they're not going to be able to move their body, but their brain may be aware of what's happening, and you're going to see it in the vital signs. They could experience nausea, vomiting, which would compromise their airway, anaphylaxis, an allergy of life and death proportion. They could have hypoxia, respiratory complications. So what is their O2 status? How much oxygen are we giving them? Their temperature could go too low. It's usually cool in the OR. Or a surgical complication that is rare, but we need to constantly be aware of, is the risk for malignant hyperthermia. And it's an adverse reaction to anesthesia where their body temperature goes really high. And then, of course, infection. So those are things that could happen while the surgery is going on. There's also adverse effects of the surgery and the anesthesia that could happen shortly thereafter, or as we're recovering the patient, or keeping them sedated. You could have allergic reactions, drug toxicity, drug reactions, cardiac dysrhythmias, central nervous system changes like oversedation, undersedation. We can cause trauma to their airway, skin, nerves. We could burn them accidentally with equipment. They could have low blood pressure. They could develop a blood clot. And chart 18-2 has more information about this in your textbook. Then, of course, we've got the specific considerations for older adults. They are at a higher risk for complications compared to younger adults because of these factors, because of that aging process. So be sure that you're mindful of these factors. In your textbook, it offers you several charts that you can just refer to for insight. I'm not going to expect you to memorize these different delivery systems, but it helps give you some understanding, okay? And then let's touch base on protecting our patient. That is a vital role that registered nurses play in the OR.